Hello, my name's Brett Montgomery. I'm a GP in Western Australia, and I'd like to spend a few minutes talking to you about respiratory inhalers, climate change and the environment. I'd like to cover what the issues are with these inhalers and also try to answer the question of what we as Australian doctors can do about the issues. And I'd like to start by asking you a couple of questions. How often do you prescribe norflurane? And how often do you prescribe apaflurane? When I first heard those words, I didn't think I prescribed them at all. I thought they sounded maybe like obscure anaesthetic gases. But it turns out I was prescribing them, and that's because they are the propellant gases found inside metered-dose inhalers. The liquid inside the canister in which the drug is dissolved, which turns into a vapour when the canister is pressed and a dose is released. The vapour carries the drug into our lungs. And why should we care about norflurane and apaflurane? We should care because they are global warming gases. They are what are called hydrofluorocarbon compounds, and norflurane, which is the one found in most of the metered dose inhalers, including all the salbutamol ones and some of the steroid ones, that is about 1,400 times as potent as carbon dioxide as a greenhouse gas. And apaflurane, which is found in a few other inhalers, is more than 3,000 times as potent as carbon dioxide. So even though there's only a few grams of the propellant in the metered dose inhalers, that small amount adds up in terms of its impact. Now, hydrofluorocarbons, you may, what I thought was, when I first heard about these, that the environmental problems of inhalers had gone away some years ago, because I'd heard about CFCs, chlorofluorocarbons, and the problems they were causing in the ozone layer. And I knew they'd been phased out through an international agreement called the Montreal Agreement. And certainly in respiratory inhalers, they'd been replaced, and I thought the problems had gone away. Well, hydrofluorocarbons don't cause problems for the ozone layer, but unfortunately hydrocarbons and CFCs are both global warming type gases. So only some of the environmental problems of these gases went away with the switch to HFCs. Hydrofluorocarbons are familiar in other parts of your life. Probably the heat pump in your fridge or your air conditioner at home contains these gases as part of the heat transfer process. But at least in those systems, the gases are reused as opposed to being designed to leak in respiratory inhalers. And we don't have a neat replacement for these gases yet, although there is another international agreement to try to phase out these gases in a number of different applications, which has a longish timeline. How much does this contribute to the problem of global warming? Well, we know that the Australian healthcare system is responsible for about 7% of Australia's overall carbon footprint, and we know from UK data that about 4% of the health system's carbon footprint seems attributable to these gases. And if you look just at the prescribing carbon footprint in general practice in the UK, about a quarter of that prescribing carbon footprint apparently comes from these inhalers. And how much does it mean on an individual level? Well, if I was using a preventer puffer per month, plus say a couple of salbutamol puffers as a reliever over the year, so 14, say, metered dose inhalers, that would be roughly equivalent to about 1/4 of a tonne of carbon dioxide pollution, the escaping propellant gases over that year, which is about equivalent to burning a bit more than 100 litres of petrol in a car. Now, many of us do burn 100, probably more than 100 litres of petrol in our cars over the course of the year. So it's not way out of proportion to our transport choices and our dietary choices in our lives. But it's not trivial either. And if it's a fairly easy thing to find alternatives to, then why not consider it? And while that's the main environmental concern of inhalers too, there is sort of some plastic and metal waste involved in their production as well. So what can Australian doctors do about this? I'd like to suggest 4 main points. 1 is being accurate in our diagnosis. 2 is achieving good disease control. 3 is switching away from metered dose inhalers to other types of inhalers where appropriate. And 4 is favouring medication regimes that don't need as many doses. I'm going to talk about each of those 4 principles in turn. First of all, trying to ensure an accurate diagnosis. We know from international evidence that perhaps about a third of asthma diagnoses and perhaps about half of COPD diagnoses can't be confirmed when researchers look carefully at patients and try to prove those clinical diagnoses. So, and for some of those people, deprescription of inhaled medicines may be appropriate. Not all of them, because some of them may just be misdiagnosed for each other and still need some kind of inhaled medicine, but some deprescription may be appropriate. So remembering the role of spirometry and careful history and examination and so on in clinching an accurate diagnosis. Second point, good asthma control, good disease control. I'm sure all of us as prescribers working with people with respiratory disease are probably familiar with patients who overuse their short-acting beta agonists and underuse their preventer medicines, their inhaled steroid-containing medicines. It's a common thing, and I'm sure you've heard before the message that we should try to encourage people to use preventers, but you might not have considered it as a win-win, not just for the patient's asthma control, but also for the environment by decreasing excessive use of short-acting beta agonists and the release of those global warming gases that's a part of the salbutamol doses. Thirdly, shifting away from metered dose inhalers where appropriate. So just to be clear what I'm talking about, here's a little picture, which you can see on the left in this picture is a traditional metered dose inhaler like the one I've been showing in this video, and as we pan over to the right you can see 3 examples of dry powder inhalers, a turbuhaler, an accuhaler and an ellipta device. And apart from dry powder inhalers, there's also soft mist inhalers for some COPD medicines these days. And so metered dose inhalers are really quite commonly prescribed in Australia and familiar to many of our patients, but this has more to do with sort of tradition and familiarity than clinical effectiveness. In fact, we have level 1 evidence that that dry powder inhalers will do just as well as metered dose inhalers for short-acting beta agonists and also for delivering inhaled corticosteroids. Now, dry powder inhalers aren't for everyone. We do still recommend metered dose inhalers with spacers for especially children, especially under the age of about 6, and also for people with poor inspiratory capacity. But that's only a minority of our patients, and most of our patients with obstructive disease actually have pretty good inspiratory capacity. Obstructive disease, it's the expiration, not the inspiration, that's the problem. Fourth point, choosing medication regimes that minimise doses. This is a way to minimise plastic and metal waste, and also if we're talking about metered dose inhalers rather than dry powder inhalers, this is a potential way to also reduce the amount of those gases that are released. So I'll give you an example. The inhaled corticosteroid budesonide, there's level 1 evidence that budesonide at a double dose once a day seems to be as useful as the more traditional approach, which is a standard dose twice a day. So for example, instead of 200 micrograms twice a day, you can give 400 micrograms once a day. And because there's the same number of doses in both of those inhalers, patients will actually go through half as many devices, saves them money, saves them waste. Another example of regimes that use less doses is the new approach of using combination budesonide formoterol inhalers as a p.r.n. agent in mild asthma. Quite a new and perhaps unfamiliar to some approach, but one that is backed up by a number of randomised controlled trials and a Cochrane review recently. And this seems to give people equivalent asthma control in mild asthma to the traditional inhaled corticosteroid plus p.r.n. short-acting beta agonist approach, while not needing as many doses. So again, cutting down on waste by not going through as many inhaler devices. So that's some of the things we can do. I'd just like to briefly talk about some objections I sometimes hear when I talk to people about this issue. One is people sometimes say, isn't this too small of an issue to worry about? Isn't it you said it was 7%, the health system is 7% of our carbon footprint nationally, and maybe some small percent of that is attributable to these inhalers. So isn't that small bickies? Well, yes and no. I think it certainly is a much smaller issue than coal-fired power stations, gas-fired power stations, and our urgent need to decarbonise our energy systems. But such is the urgency and magnitude of the climate change problem, I think we actually need to do everything we can as soon as we can. And this is a pretty easy change, potentially, for many people. And it's something that I, as a doctor, have some control over in a way that I don't have control over power stations. So I don't think it's too small to worry about, even though in context it's not, I'm not blaming people with asthma as being the main cause of our climate change situation by any means. Another objection I sometimes hear is, isn't it too expensive? Aren't those dry powder inhalers more expensive? Well, internationally, in low-income countries, that is an issue, I understand. Within Australia, it's actually much of a muchness. The short-acting beta agonist dry powder inhaler is a bit more expensive than the short-acting beta agonist metered dose inhalers. But once you move to inhaled corticosteroids and to combination inhalers, not so. If you there was a good article about 3 years ago in Australian Prescriber Journal, and they looked to see what the cheapest inhaled corticosteroid inhaler was and what the cheapest combination inhaler was, and they actually found it was a dry powder inhaler in both cases that was the cheapest. So don't let the finances put you off necessarily. A third objection, is it too hard for my patients to learn a new device? It might be for some, but I think particularly perhaps people with limited cognitive capacity, but I think for many people it's not usually difficult. My experience of talking to my patients through this has not been that it's difficult at all. In fact, I think dry powder inhalers are arguably easier to use because there's not the issue of having to time the actuation of the device with inspiration. There's not the need to use a spacer. A lot of people don't like using spacers. Those problems just go away with dry powder inhalers. So I wouldn't let fear of difficulty be a barrier, except in special cases. And finally, I've been asked, won't it make my patients feel guilty if I bring this up with them? What if my patients got so worried about their medicine contributing to global warming that they stopped taking it and then they got worse disease control? Well, I think that would be terrible if that happened, and I think it's important to counsel people carefully about this. I do think good disease control is paramount, but I think guilt isn't the only thing that we could make people feel by discussing this issue. The flip side of guilt is empowerment. I actually felt empowered when I discovered, as someone with asthma, that I could shift from metered dose inhalers to dry powder inhalers. I'd already made other lifestyle changes in my life which had made probably bigger impacts than shifting my inhalers would have, but to be able to do at least one other extra thing in my life to lessen my personal footprint really made me feel good. So I think there's we should remember, while we're mindful of the possibility of guilt, also the benefits of empowering our patients to make a further difference. So in summary, I hope it's useful to be aware of this issue for you. There are definitely greater threats to our planet than respiratory inhalers, and good disease control is the priority, but this is a fairly easy change for many people. It's appropriate for many people. It's low-hanging fruit, and it's something that doctors and our patients have some control over. So let's not ban metered dose inhalers, but just be mindful when we're prescribing them and discuss the options with our patients and reach good shared decisions together. Thank you for watching. I'll just finish up with a few slides of references so that if you'd like to look into the things I've talked about and learn anything more, you can follow those links. Thanks again.